Hello, I am Kim Young-soo, and I will be presenting on the topic of a 10-year clinical evaluation of Neobiotech implants. Over this session and the next, I would like to share how I have developed my practice while gaining experience with Neobiotech implants and learning the CMI concept. Since I also work in a private practice, I have been contemplating what makes an implant suitable for use in a private practice. I believe a good implant should meet the following conditions. First, it has to be easy to place. Second, it should be usable in various clinical situations. Third, it has to be easy to maintain. Fourth, it must provide long-term stability, and additionally, I think it should be cost-effective because high prices can be burdensome. It wouldn't be an exaggeration to say that there are a wide variety of implants used worldwide, with hundreds of different types. And we have the Neobiotech implant that we are using. What do you think about such a variety of implants, from IS to IT and EB? I believe you must have a variety of numerous different and varied experiences with implants. At first, I also didn't have the opportunity to learn about the CMI concept, so there were times when I placed implants before understanding the CMI concept. Starting in 2017, I began to learn about the CMI concept, and I became familiar with it and applied that concept in my practice. Dr. He visited my practice in Yosu City and gave a lecture on anytime loading and the CMI concept. At that time, I was also greatly impressed. So, I will share my understanding of the CMI implant concept. In the maxilla, it's about achieving self-compaction and bicortical fixation. To achieve this, a tapered implant design and a strong thread macro design will be required. I also believe that a special tool, namely a sinus kit, will be necessary to reliably elevate the sinus membrane. In the mandible, it means minimizing trauma in hard bone and achieving optimal fixation using precise osteotomy. To achieve this, implant drilling and screw tapping will likely be necessary. Now, I will introduce my initial experience with CMI implants. This is a case of a patient who had tooth number 26 extracted and received an implant procedure. The CT scan results showed that the alveolar bone condition was good, so there was no need to touch the sinus, and the implant was safely placed using standard methods. I carefully tightened the cover screw securely, ensuring it was in place, and sutured. After 3 months, a second surgery was performed, and after completing the final restoration, a panoramic X-ray can be checked. This is a clinical photo after completion of prosthesis. 2 years later, this patient came in complaining of discomfort in another area. In particular, due to severe periodontal disease in the area of tooth number 37, extraction was necessary. Approximately 4 years later, the extraction was performed due to significant mobility and severe pain in the tooth number 47, and unfortunately, 8 years later, the tooth number 16 was also ultimately extracted as a result of the periodontal disease. However, the implant placed in tooth number 26 was being maintained stably. This is the radiograph from 8 years later, and this is what it looks like 9 years later. An implant was completed in the area of tooth number 16 extracted at that time, and tooth number 26 was still being used well. I will show you another case. Teeth number 36 and 37 were in a situation where extraction was required due to periodontal disease. We planned to first perform a bone graft and then place the implant. After the extraction, we first checked the condition of the gums and decided to perform the bone graft based on the CT scan results. After forming a full-thickness flap, we proceeded with the bone graft using allograft bone in the area of bone deficiency. We covered it with a non-resorbable membrane and sutured it. After 4 months of healing, we performed a re-entry and confirmed that the bone graft had integrated well and matured. After that, we placed the implant, and this is the clinical photo after the completion of the prosthesis. This is the panoramic X-ray after the completion of the prosthesis. As a result of a 6-year follow-up, it was well maintained without crestal bone loss, and we proceeded with an additional implant due to damage to the opposing tooth. This patient came in during the early days of our practice and is the father of my wife's friend. The existing long bridge in the anterior region was fractured due to decay in the abutment. To place the implant, the existing bridge supported 7 units, meaning 7 teeth, so we aim to place at least 3. However, due to significant tension on the lip side and the alveolar bone being very thin in the anterior region, we determined the prognosis was uncertain and could only place 2 implants of 4.0 diameter by 10 millimeters. Later, the patient came in due to discomfort in another area, and they complained of pain caused by pulpitis due to deep cervical abrasion. As a follow-up result, even after 7 years, the bridge using the implants was well maintained. Looking at the X-ray, it was observed that there was a slight bone defect due to insufficient depth of implant placement. However, it is being used stably without any major issues. This is a patient who came in requesting an implant in the posterior area of the first quadrant. Number 15 required extraction due to severe periodontal disease. Due to the low amount of residual bone, additional bone grafting was performed through lateral elevation, and the implant was placed using a 2-stage method. Afterward, a lateral window was created, and bone grafting was carried out. 6 months after healing was complete, the implant was placed again. This is the completed final prosthesis. After 7 years of follow-up, the patient is using it well without any significant discomfort. When I asked the patient about the condition on the left side, they said there are no teeth on the left, but since there are teeth on the right, they have no major difficulties eating. This is the follow-up panorama radiograph after 7 years. In the periapical radiograph, it was also stable and well maintained without any crestal bone loss. Through these initial experiences, I became convinced that CMI implants are a very good choice. Now, indeed, let's take a closer look at CMI fixation. This is a concept for classifying the unique implant fixation that Neobiotech has. CMI is a method that classifies fixation by subdividing the crestal, middle, and apical areas. Especially in the maxilla where the bone quality is weak, it is advantageous to use self-compaction for implant placement. Here, you will see a detailed image of an implant that was carefully placed using the method of self-compaction. However, in cases where sinus pneumatization has occurred and the position is lowered, Class 2 CMI fixation is needed to place the implant while elevating the maxillary sinus. In this case, initial fixation is strengthened through bicortical fixation. Looking at the classification of CMI fixation in the maxilla, Class 1 CMI fixation is the case that does not involve the maxillary sinus. Class 2 involves elevating the maxillary sinus membrane while placing the implant without bone grafting. Class 3 refers to elevating the maxillary sinus membrane through a crestal approach, accompanied by bone grafting during placement. Class 4 involves performing bone grafting and placing the implant through a lateral approach. Comparing the differences between Class 1 and Class 2, Class 1 does not involve the maxillary sinus, while Class 2 slightly elevates the maxillary sinus membrane to achieve bicortical fixation. At this time, a unique instrument from Neobiotech called the S-reamer is essential. The S-reamer is a reamer that can reliably elevate the maxillary sinus membrane without perforation. Through the animation, you can see how the maxillary sinus membrane is elevated along with a thin bone disc. In the past, an osteotome was used to perform medial elevation of the maxillary sinus, but using the S-reamer allows for a more stable exposure of the maxillary sinus membrane. This makes medial elevation significantly easier and increases the chances of success. I believe that the S-reamer is essential for this. According to the literature, in cadaver studies using the S-reamer, the risk of perforating the maxillary sinus membrane was significantly lower compared to using an osteotome. Additionally, there are reports that the greater the elevation amount, the higher the possibility of perforating the maxillary sinus membrane. Next, I will introduce a case. This is a case plan for an implant after extraction due to severe periodontal disease in the area of tooth number 16. This is a CT scan image taken after the extraction. This shows the occurrence of bone loss in the palatal area. Through the medial elevation of the maxillary sinus, we plan to place the implant doing GBR palatal area. If you look at the clinical photo after healing post-extraction, you can see the formation of a full-thickness flap. Now, we are elevating the maxillary sinus membrane using an S-reamer. After confirming that the maxillary sinus membrane was safely elevated through probing, we performed additional elevation using a hydraulic kit. Next, we placed the implant and performed bone grafting in the areas of bone loss on both sides. Afterward, we sutured with a collagen membrane. This is the panoramic radiograph after the implant placement. This is the panoramic radiograph after the healing period and completion of the final prosthesis. The CT scan after 3 months showed that the alveolar bone in the grafted palatal area had stabilized. The follow-up photo after 5 years shows that the lower border of the maxillary sinus has been remodeled stably. The clinical photos also show that the healing has progressed well. I will show another case where implants were placed on tooth numbers 14 and 16. Due to damage to the existing prosthesis, there was a root rest remaining in the area of tooth number 14. For tooth number 16, the plan was to place the implant through a medial elevation. After removing the root, immediate placement was done in the area of tooth number 14, and the maxillary sinus membrane was exposed using an S-reamer in the area of tooth number 16. Let's briefly take a look at the use of the S-reamer. This shows the maxillary sinus membrane well exposed without perforation. After elevating the maxillary sinus membrane using hydraulic elevation, the implant was placed. Since the initial stability was insufficient, a cover screw was used and suturing was performed. This is a panoramic radiograph after the implant placement. After healing period, a secondary surgery was performed on tooth number 16. This is the intraoral picture and radiograph after completing the final prosthesis. due to damage to the existing prosthesis on tooth number 15. Secondary caries worsened, and the patient requested an implant. After performing the extraction, the implant was placed, and efforts were made to achieve Class II CMI fixation at that time. Class II CMI fixation is advantageous for securing initial stability. As a result of checking the initial stability through any check, we confirm a good initial stability of about 76. We completed the implant placement by achieving Class II CMI fixation. The patient had a long bridge spanning from tooth number 14 to number 17. However, due to a root fracture of tooth number 14 and a tooth fracture, an implant became necessary. After the extraction and healing period, when we formed the flap, we could see that the buccal bone of tooth number 14 was severely destroyed. When the implants were placed in the areas of number 14 and number 16, a lot of threads were observed to be exposed. In this area, autogenous bone was harvested and initially grafted, followed by additional bone grafting using allograft. After grafting, a collagen membrane was used to cover the area. This is suturing, and after 4 months, the second surgery was performed. We could see that the volume of the healing bone was well formed. In the follow-up photographs that were meticulously taken after intervals of 3 and 5 years, we were able to thoroughly confirm and verify that the level of the alveolar bone has been consistently and remarkably well maintained over this extended period of time. This is the appearance after 6 years. Panoramic X-ray. As of now, the stable condition around the implant has been maintained. It's the immediate placement case for number 24 and number 26. A bridge was broken. There were roots remaining in the number 24, number 26 areas. There were plans to place extra implant in the pontic area. As you can see in the clinical photo where extraction was required, the implant was placed after debridement of the granulation tissue. It was important to secure MI fixation well after the immediate placement following extraction. After the implant placement, initial stability was well secured, and after attaching the healing abutment, suturing was performed, especially in the area of the large extraction site of the number 6 molar. We tried to minimize the gap with the gums by using a wide diameter healing abutment. This is the appearance after suturing. After a healing period of 3 months, we took impressions and made the prosthesis. After completing final prosthesis, we checked the panoramic radiograph. 1 year after the surgery, the radiograph showed decay in the adjacent tooth area, so we performed an endocrown. 3 years later, we followed up a patient for a bridge fracture. We found they were using the implant well without any crestal bone loss. That's all I have prepared for today. Next time, I will show you more about implant cases using the CMI concept.